we're very excited to have Dr. Allison Janda with us. Dr. Janda is a cardiothoracic anesthesiologist and researcher that's interested in studying outcomes after cardiac surgery, as well as how intraoperative practice variation impacts outcomes, the patient experience, and cost after surgery. She works a lot with MPOG, which is the Multicenter Perioperative Outcomes Group, which I'm sure most of you know in some capacity. It's an international consortium of perioperative databases coordinated here at the U of M. And they perform retrospective studies pertaining to her interests in perioperative outcomes. She aims to apply the resources of MPOG to aid in the development of pragmatic clinical trials to study intraoperative care, postoperative complications, costs, and patient-centered outcomes. And she leads the MPOG Cardiac Anesthesia Quality Improvement Subcommittee, which does focus on the synthesizing the literature into evidence-based quality measures and quality initiatives pertinent to cardiac anesthesiology. So we are very thrilled to have her here with us today and look forward to her talk. A couple of housekeeping items. Please make sure that your audio is muted. It should be. Sharing your video is not expected. This will be recorded. If you have any concerns, please go to the chat or Q&A and advise any of your concerns around this being recorded. There will be one contact hour of CME provided for today's session. These are kind of relevant disclosures for today. Here is the information for the CME. You can use this QR code to register your attendance. We will also, we will be able to provide this later and after the talk is over for anyone that needs it again. So let us know if you missed this, and we will make sure to provide this to you. So again, thanks for coming. If you have any questions or suggestions for future speakers, please reach out to myself or Daniel Koski or Holly Nielsen. Our emails are here, and we would love to hear your thoughts or suggestions as we kind of continue to move this seminar series forward. So again, thank you for attending. So I'm going to stop sharing, and now I will turn it over to Dr. Janda. Thank you for coming today, and we look forward to hearing your talk.
Great. Thank you so much for having me. Sorry for interrupting you right there. I was trying to pull up my slides. I didn't see the camera. And thanks again for the invitation. I'm really excited to speak to all of you today. And the title of my talk is Implementing Evidence to Promote Practice Change. And so I am currently a clinical lecturer. In 2 weeks, I'm an assistant professor that just went through. So I'm excited. Thanks, Donnie. And thanks, Mike. Within the Department of Anesthesiology. And like Mike mentioned, I work with the Department of Anesthesiology, but I do mostly cardiac anesthesia. I did my fellowship here a couple years ago, and then have been here since. And I just completed a T32. And during that research time is when I primarily work with MPOG, but also have the pleasure of working with Mike and Donnie. And so to round out my disclosures, I don't have no conflicts of interest, but I do have financial relationships with the PCORI contract for research with Dr. Ketterpaul and Dr. Avedon, which is a pragmatic clinical trial studying patient-centered outcomes and recovery after 2 different types of anesthesia. And then I'm a co-investigator on a R01, which I will discuss today a little bit as it pertains to MPOG quality feedback emails, as that's kind of the substrate for the R01. And I just finished my T32, and I also have had research support in the past from Becton Dickinson and Company, but there's nothing in this presentation pertinent to that. And I do not include or discuss any off-label or investigational drugs. So today I really want to talk about what's known as the 17-year time lag and how to get rid of it. So there's a kind of a landmark paper that discussed the time from when a paper is published to when the results are actually in common practice. And so 17 years is a very long time, from eating blocks to throwing caps up in the air at graduation. And so that's really unacceptable time lag for medicine and the rate of change we want to be seeing to best care for our patients. And so I'll kind of go through a quick outline and the sections that I'll discuss today, but overall, I'm just going to discuss tools that we have utilized in the Department of Anesthesia or within MPOG to promote practice change and improvement based on evolving evidence in anesthesiology. And the keyword's evolving, and we keep revisiting these things. So I'll definitely reserve some time for questions at the end or any feedback you all have about these things, because we'd be interested to hear what you have to say. And so I'll focus on 3 different examples. The first is within the University of Michigan for approval of use of dilute peripheral norepinephrine. I'll explain kind of what that means, but that's a vasopressor drug that we use in the operating rooms. And then nationally, through a quality collaborative within the Multicenter Perioperative Group, Perioperative Outcomes Group, or MPOG, called Aspire, which is the Anesthesiology Performance Improvement and Reporting Exchange, which develops measures based on the data that is gleaned through MPOG. And then synthesizes these into provider feedback emails. And I'll talk about some kind of impactful projects that we're working on pertinent to all of these findings. So the road to practice change is very long, and it has a couple of detours, which are not shown here in this image, but sometimes it feels like a desert. And so you have to really recruit a team to help get everything accomplished from the get-go. And so first, we're going to talk about kind of the overarching goals for these 3 examples that we're discussing today, are really to improve outcomes in quality of care by helping provide the data back to providers or give them the tools that they need to be practicing top tier, cutting edge medicine. And so this comes in the form of simple clinical information updates and updates of approved uses of different medications or different protocols within your institution, to more detailed feedback reports for, say, department chairs or quality liaisons at different departments, looking at the performance of their providers at the case level and the provider level on a number of different measures that are important to our patient outcomes. And then also as formulated as feedback emails to individual providers. So even if a number of people take part in a case for anesthesia, for instance, you get these feedback reports that we get monthly. And so I'll go into details here. But the overarching goal is really just all of these things were to help provide data and feedback to our providers, both within our institution and elsewhere. And so first we'll discuss the example that's on the departmental level with the approval of use of dilute peripheral norepinephrine. And I know everybody on this call is very cardiac focused, so you may have heard about this drug before or know it through and through and have a PhD in pharmacology. But just to make sure we're all on the same page, I'll go through some background just in case people aren't as familiar. But overall, end organ dysfunction is a major issue for surgical patients, which can significantly impact quality of life, recovery after surgery, and cost of care. And you all know this extremely well, as it's all amplified within cardiac surgery. And so we are really focused on preventing AKI, myocardial injury, and stroke, for example. And there have been multiple papers which have shown improved outcomes while maintaining intraoperative blood pressure. But vasopressor therapy, specifically the choice between 2 different medications, phenylephrine and norepinephrine, are debated when it comes to general anesthetic cases. For cardiac, we end up using norepinephrine a lot more frequently for a couple of reasons I'll go into. But overall, our goal is to reduce all of these things or get rid of all of these things if possible. And so in non-cardiac anesthesia cases, but still focused on cardiac principles, studies have shown that norepinephrine is potentially superior to phenylephrine for some patient populations, giving the improvement in cardiac output seen with the beta effect of norepinephrine that phenylephrine lacks. Specifically, this has been shown in ICU patients where there was a drug shortage of norepinephrine, and phenylephrine use increased during that time because there was no or very little norepinephrine available. And phenylephrine was associated with the increased mortality during that norepinephrine shortage. So they took kind of advantage of a really crummy event and turned it into really quality research to help educate us on what to do in the ICU population when it comes to vasopressor support. In the obstetric population, a few studies have shown improved cardiac indices with norepinephrine compared to phenylephrine when used during cesarean section too. And so just to kind of compare pressor versus pressor, one of my former mentors at Vanderbilt where I did residency, actually designed this really cool infographic. And so this kind of goes over the potency and different dose equivalencies of these two medications. So it's not a 1 microgram per 1 microgram, in concentration and potency, but about 100 micrograms of phenylephrine is about 4 to 8 micrograms of norepinephrine. And so in light of that kind of outcomes data that exists in kind of peripheral populations to the operating room, there was a whole set of new safety data that really came out in 2019. And so I'll summarize this data for you, but we wanted to then say, why are people in the operating rooms using phenylephrine more often than norepinephrine? And we looked at our protocols, and the dilute version was not approved necessarily to be given through a peripheral IV. So of course, people are using phenylephrine more often. And so with the data kind of supporting the potential superiority of norepinephrine for vasopressor support for intraoperative hypotension, we wanted to make sure that our providers had up-to-date clinical protocols and up-to-date approval of use for this medication in light of the safety data I'll cover. So historically, we've used phenylephrine for a primary vasopressor in the operating room, and we have not used norepinephrine because of concerns of tissue damage with extravasation. So when an IV blows or infiltrates, it can cause additional tissue damage. So this has pretty much been debunked with norepinephrine at dilute concentrations. And so one of our, and Nirav Shah, the quality portion of MPOG director, and Carlo Pancaro, one of our OB anesthesiologists. Carlo had trained in Europe where they give norepinephrine all the time through peripheral IVs, and was wondering why this practice was the case, and went back to his previous institution and did a retrospective study that looked at over 14,000 patients, and they showed no increased complications of IV stabilization. And this was published in Anesthesia and Analgesia in 2019. And so they had a lot of patients, again, over 14,000. They did see some infiltrations, which is reasonable and understandable. It's a complication of a known complication of having a peripheral IV is that it can infiltrate. And they found that there were no related complications to norepinephrine extravasation. So the estimated risk is very, very low of complications. And so we use that safety data to approach our pharmacy boards and our clinical quality committees to get all of this approved for use in the operating room. And there were a lot of different presentations to make sure that everybody's on the same page. And so I think the key to presenting this example is that there are a lot of different people involved in a small decision. So just approval of use of a medication that had already been in use before required a number of different presentations, both M&Ms and CRNAs, education, as well as PACU areas to make sure all the up to date on how to use the Alaris pumps and the different formulations of the medication. So these are some examples of the kind of materials that we sent out, showing people what they look like and how to use them so that there couldn't be any additional errors or sequelae of this new change. And so the lessons learned from this were to plan ahead, gather materials, and developing proposals and scheduling committee meetings because they take a lot of time, as well as getting buy-in from all involved parties. And then disseminating the information was time-consuming, but very helpful in solidifying and disseminating the information throughout the department. And then continuing to reassess any potential implications of change are crucial. And so to go through the overall, I see Dr. Lukoski had a question in the chat. Who makes the dilution? Is it made only by pharmacy? Just wondering about safety issues. Correct, only made by pharmacy. And so the pharmacists compound the syringe at 4 micrograms per mil, and that's the only approved use. Nobody, there's what was one incident where somebody had compounded themselves and they were told never to do that again, and it was a quality report. So there's always something that you always have to manage the implications of any decision. And it is very clear that this was not to be compounded by individuals because the math can be a potential source of error or distraction in the operation.
Can I ask a clarifying question on that?
Yeah.
All right, so what about stat needs for a bolus. So if you actually don't have it, then is that considered a barrier from a anesthesiologist that you then need, to ask pharmacy for something that you would otherwise have readily available?
Yeah, and so that's something that we actually discussed heavily with pharmacy about how much of this to have readily available every day for people to use. And so they look at their monthly use reports of norepinephrine, and they actually saw that people were using the 20 cc syringes very frequently, and they looked in the chart and saw that they were in the context of infusions with patients over 100 kilograms. So when they said, oh, we need to make a larger syringe of this for the infusions. And so it's the same concentration, so you can use it as a bolus or as the dilute infusion that is only available on a specific Alaris tubing channel. So this is the syringe pump and this is the tubing pump. So the menus are not accessible from either type of Alaris adapter. So there's extra safety barriers for people to not accidentally spike the wrong medication, but also safety barriers written into our protocols and our dissemination of information that it was very clear you are not to compound this yourself. It's done by pharmacy. They will have X amount available, and they're going to be looking back at the last month. And if most of it's being used and they had to compound more that day, they increased their kind of allocation for how many they need to have ready. And so I've never gone to the pharmacy and not had a syringe available at the CVC or at UH. And so I think there was 1 week where the demand at UH was higher and we heard about it and they escalated their own supply, which was great. But it does take some time to compound, a couple minutes really to compound. But they like to do this in advance, obviously. And then, so it does limit the accessibility if you do not have it in the room already. But most of our providers, if there's a patient with a slightly depressed ejection fraction or other or anticipated hypotension, I don't even have to ask for it. They already grab it and bring it to the room and have it there. And so that's a nice kind of example of the use patterns of change. So to quantify these patterns of change for non-cardiac cases without a central line, so this is just through peripheral IVs, the use of dilute norepinephrine was 2.1% of cases and 3.8% of cases receiving vasopressors. And it went up by September 2020 after we did all the education in November of 2019 through January of 2019, right before COVID happened. And then it's gone up over fivefold. So instead of the 3.8% of cases receiving vasopressors getting some dilute norepinephrine, now 21.4% of cases that receive vasopressors get some dilute norepinephrine. So essentially, the demand was there from the providers. They wanted to be using this medication, and we wanted to make sure that we could meet those people where they were, but also educate the entire community of anesthesia providers at our institution while we were updating our protocols. And there's a lot of cool future studies and directions. There's a number of pilot trials registered on clinicaltrials.gov, or a handful, looking at phenylephrine versus norepinephrine in the general surgery or non-cardiac population. And one of the pilot seeds won the IRS Impact Award in 2018. And then MPOG is working on a number of vasopressor variation studies and vasopressor use studies. And so now this is where I'll move to the National Quality Collaborative within MPOG of developing ASPIRE measures. And I'll take a more of an actual cardiac-centric approach now. We were kind of just talking about perfusion before, but now we're talking about actual cardiac surgery and anesthesia. And so the rationale for the development of ASPIRE cardiac measures, and ASPIRE is a realm within MPOG. So MPOG, I have a slide later that shows that MPOG has two agendas: research and quality improvement, and ASPIRE is the name of the quality improvement arm. And the goal or rationale for developing these measures is to prevent organ dysfunction and prevent bad outcomes in our patients, or help educate people to have better outcomes for our patients. And again, we want to eliminate the same things that we were doing by helping update the protocols at Michigan. because we've seen improved outcomes while maintaining intraoperative blood pressure, controlling blood glucose, avoiding hypothermia, et cetera. So within MPOG, there's the research arm and the quality arm. MPOG was formed in 2008, and it has over 50 hospitals, which include 13 million cases, 27 billion observations. It's just an insane amount of data. And monthly, this data is synthesized into quality reports based on the measures that are developed by the quality committee. And that is just like an amazing direct application of a 30-day turnaround. They upload their data and you get your report that next month for your cases the month before. And so that's a lot shorter than 17 years. And so this is a map of all the cases that participate in MPOG. So you can see there's a majority of institutions in the beginning were from Michigan, but we've kind of expanded elsewhere and have a gap kind of in the central north of the state of the country, but really coast to coast, there's quite a few institutions, big and small, that participate. And they get these quality measures as a form of dashboard. And then they can also obtain emails if they submit a high enough quality of data and have the technological support to undergo that. And so MPOG, again, over 50 institutions, tons of data, and that all feeds back into these Aspire measures. Some examples that I put here are acute kidney injury because it's a laboratory-based measure, and MPOG includes all of the labs 365 days before and after surgery. We can tell if somebody had an AKI if they had their creatinine checked. The outpatient ortho knee procedure likely does not have a creatinine postoperatively, but a cardiac surgery definitely does. And so there are a lot of different ways that we can adapt these measures to apply directly to cardiac cases. And that you can see here, I've included some that are really pertinent to cardiac, such as acute kidney injury and glucose management and blood pressure, but also post-op nausea and vomiting isn't as common after cardiac surgery for a number of reasons. And so to develop the measures, the General Measure Committee meets quarterly, and this includes representatives, the quality champions from all the institutions within MPOG. And there's a person at each institution that is designated as that quality champion. And then at these quarterly meetings, we discuss new measures, whether we need to re-examine any current measures, and then automatically every 3 years, each measure comes up for re-examination. And so there's a work group that meets, and that's picked by it's an opt-in, but by expertise on a specific topic, and then updated after that group presents what they think about the measure. And these are non-University of Michigan people, non-coordinating center people. And so we've also established subcommittees to develop subspecialty specific measures, which include cardiac, which I lead, peds, and OB, which are led by 2 other individuals. And our cardiac subcommittee casts a wide net. So there are a lot of different institutions that are participating. There's 16 labeled here, but we have 18 now that just joined very recently to the subcommittee. And we also meet quarterly and put our heads together to discuss how we can adapt these measures to be more pertinent to cardiac anesthesia and cardiac surgery. And so this was just formed in the beginning of 2020. And so there were a number of general measures that are pertinent to cardiac, but weren't perfect for cardiac. So for example, blood pressure. Any blood pressure or any case with a MAP less than 65 for 10 minutes would get flagged if you are a general anesthesia case. There are very, very few cardiac surgeries that would not get flagged in that circumstance for a number of different reasons. When we're initiating bypass, separating from bypass, on bypass, treating vasoplegia, despite maximal efforts, sometimes that is not met. And there are times where you do not want hypertension during cardiac surgery. This blood pressure is not relevant. It's pertinent as far as the topic, but this specific measure is not relevant. Same with glucose management. Glucose control in cardiac surgery has been shown to be very, very important to prevent surgical site infections. And the glucose management is if it's been checked and or treated if greater than 200, which is not adequate for cardiac anesthesia or cardiac surgery. So we on the cardiac subcommittee have our work cut out for us, but we have developed one measure and are working on the second one. And so there are a total of about 200,000 cardiac cases within MPOG, and over the last 5 years, it's about 150,000. I truncated this for COVID just because it would have been a weird year to show, but from 2018 to 2019 of that academic year, there are about 34,000 cardiac cases. And that's pre-slight refinement of how we're identifying cardiac cases, because we don't have it as granular as, say, STS for the actual case type. But we've developed 2 measures since temperature management is very important to help mitigate coagulopathy post-bypass, and was an important priority for the group. We all voted on what the topic should be, the first one to tackle. And they thought that a post-cardiopulmonary bypass hypothermia avoidance was very pertinent. And so we defined this as anything less than 35.5 degrees Celsius was determined as hypothermia for the last temperature obtained, and preferentially core temperature obtained in the operating room. And so we're not talking about on bypass or immediately post bypass. We're saying that you should keep the patient at least to be 35.5, with a few exceptions, which we have worked into the specification. And then the next measure that the group wanted to tackle is Tempo 7, or the cardiopulmonary bypass hyperthermia avoidance. Since there has been a lot of cerebral outcomes data that has shown that hyperthermia while rewarming has been shown to have some detrimental effects, and and there's actually an AQIP measure, which is a national organization that also provides cardiac anesthesia, or provides measures throughout the entire case, but they measure they say that you shouldn't have outlet temperature greater than 37.9. And where we are measuring the temperature, it's a great question. So we capture all the temperatures within MPOG that are measured. And so we have to delineate which ones we would like to use within our measure. So we capture all the temperatures at the end of the case and then rank order them. And the temperatures that are available at the end of the case are usually temperature bladder, nasopharyngeal, esophageal, nose, rectal, skin temperature. And if they arrived in the ICU and checked like an intra-auricular temperature or something like that. But the pump temperatures are not being recorded at that point. So that's not something that would be a problem. But we take the last core priority temperature. And if the last temperature is non-core, we have a code written so it looks back 15 minutes to see if you just disconnected the core temp just prior to leaving the operating room as part of breaking down and getting out of the operating room.
The reason I asked in part is because in our perfusion registry, I believe we asked the centers which temperature they actually use, even though they record a lot.
Yeah.
I was just curious, in your measures, is it center specific to the actual temperature location that they're actually using as their core?
And so, yeah, I totally agree, especially for on bypass. And that's one of the things that we're debating. And we've recruited some perfusionists to help us with specifically to make sure that we're incorporating all of their input too in the on bypass hyperthermia avoidance or hyperthermia avoidance. But for the post bypass hypothermia avoidance, we would prioritize a core temperature, which we're saying bladder is more of technically the nasopharyngeal is a core temperature, but we consider it a peripheral temperature in the operating room, in that we follow that same conceptual model and prioritize bladder temperature over nasopharyngeal in this specific measure. But that's a good question. And it gets kind of into the nitty gritty of kind of how people are labeling their probes and everything as well. And so as long as you can only be as good as your data. And so there are going to be instances where they flip the measurement or something like that, and we'll use a nasopharyngeal or maybe even a skin temperature. I'm not sure why they would do that for cardiac, but you never know. And there are always fringe cases to kind of prove us wrong. So we're in the process of finishing validating this measure and pushing it out to the other institutions. And then we're in the process of creating the Tempo 7 measure with a perfusionist work group as well. And so the current measures all get pushed to a dashboard. And so there's the cardiac anesthesia specific dashboard. There's also a peds anesthesia dashboard and a OB anesthesia dashboard, and they include the somewhat pertinent or designed for that subspecialty. So this is an older picture from this past summer, but the Tempo 6 measure is not live on this yet, but once it is, it will pop up as our front and center first actual cardiac designed for cardiac measure. And so you still have access to other measures and you can review those cases but with a grain of salt of knowing that they weren't designed perfectly for that specific case. And so it's a lot of cleaning and coding because we want to make sure that whatever feedback we're pushing towards back to providers through this dashboard or through their emails like this is accurate, because we do not want them to get these emails, say, my pulmonary O1 tidal volume, I was 9 out of 9 that month, but say I was 5 out of 9. And I look at them and I see that they're bronchoscopies or something. And then you say, well, those should be excluded because I had no control over the tidal volumes during that case. They were jet ventilating or doing some other airway management. And then you totally disregard the entire email because you're frustrated and walk away. And that's the last thing we want. So we want to make sure we're putting all this work into something that's digestible for folks, useful for people, and also doesn't overstate the data in that we are cognizant of what is not clean or what is not good, and we exclude those. So it's not perfect, but it definitely helps me identify cases that I need to improve on certain aspects for. And it's actually this provider feedback is part of our, there's MOCA credit for it. So you get like 25 CME specific MOCA points for anesthesia for our ABA. And so they've also felt that it's a high yield thing to be having us review our own cases every month. And if you do that for 12 months, you get the 25 points. So it's, people have different incentives for things, but it's helpful to have in your inbox monthly from the month before, not 10 years ago. And so for some additional future impact and early results, so that's a great question. And so the data on the dashboard currently are crude, but we have just come up with an AKI adjustment. And they're working on a mortality adjustment. So where it wouldn't be specific for cardiac for those things, that's something that once we push out the general adjustment model that we're going to start working on for the cardiac subcommittee, because there's been a lot of excitement about tackling AKI specifically. And so right now we're just trying to work on a kind of somewhat low-hanging fruit with the temperature measures, because we know that data really well from our other measure development. But once we get the standard or the adjusted AKI measure pushed out, then we're going to bring that up as an exciting next thing for the cardiac group to work on, which I'm very excited about. But that's a really excellent question.
Do you get pushback on the crude data as the patients are sicker?
Appropriately
and blah, blah,
so.
Yeah.
My patients are, and sometimes it's general as my patients are just sicker, and sometimes it is that they're sicker, and sometimes it is that they you're an ICU physician and they put you in all the horrible major oncology cases, and those are really hard cases and have some end organ issues pre-operatively. So sometimes it's 100% spot on that your patients are sicker, and people do get a little bit some people get defensive, but the intention is to flag the case, not fail the case. So we're looking to just say, hey, this merits a look. And so take a look at it, see if you think there's room for practice improvement. We're not trying to say or point fingers here. We're just shedding light on potential areas for improvement is really what our goal is, fully acknowledging that our measures are not perfect because the data is not perfect. And so if we don't have the case type, we can't figure out what kind of case it is to exclude or include. And so it becomes really difficult if their institution is not good at that. These quality measures are highly motivating for people to increase their data quality of what they're contributing to MPOG, because their providers go back to the quality champions and say just that, and say, why is this counting, or why isn't this counting? And they then look back at how they're mapping, and it just creates a better database in the long run. But that's why also that we continue to review measures as issues come up and adapt them to, like Donnie had mentioned, different institutions have different quirks or different things that they do differently, or different ways of charting things. So when we onboard a new institution, Nirav and I actually review each institution's data and make sure that the mapping is appropriate in the context of the measures that we're pushing out specifically, and then common research questions. And so looking at this data, and all models are wrong and some are useful. Very true. So we're trying to maximize the utility of these, and with full assessment and of the accurate statement that they're not perfect. And so we did a study trying to assess if there was a cost savings or cost avoidance potential with participation in Aspire. So we merged data with the Michigan Value Collaborative, or MVC, and did a difference in difference analysis, looking at the before and after Aspire quality improvement participation in those between institutions who do participate in Aspire and who do not. And so there were a pre and post period, both for the did and did not participate for both of those windows. And so we hypothesized that participation in Aspire was associated with reduced payments of high volume procedures included in the MVC database. The MVC database doesn't include everything, but it does include incredibly high volume procedures. And so this is all presented with the caveat that this is unpublished data. We're working on submitting the manuscript, hopefully next week. And so for our results, for all payers across all procedure types, and caveat on the word all, this is Blue Cross Blue Shield network, Blue Care Network, Blue Cross Blue Shield in Michigan, and the fee-for-service Medicare payments. So it's not 100% of the every single payer, but it is the great majority of payers in the state of Michigan. And so this is just Michigan data. So for all payers across all procedure types, we did find a significantly greater reduction in post-discharge and total hospital payments for procedures performed in Aspire hospitals compared to non-Aspire controls. So post-discharge payments, so people did better after they left as far as cost goes, meaning that they had some sort of savings in their care at some point. And total episode payment was $719 less for the Aspire hospitals. So we find this to be helpful data. It's cost, it's not outcomes. We're looking at outcomes. And so one outcome is looking at one of our anesthesia attendings, Ben Cloyd, has a FAIR grant with partially supported by the ABA to help determine if participation in MOCA and your scores on your CME and continuing education correlate with your Aspire performance. And then we are also working with MPOG, or MPOG is working on a R01 with the National Medical Library agency within the NIH on an R01 that we just found out was recently funded. And so I'll talk about that under the bin of provider feedback emails. And so the title of the R01 that I just mentioned is a scalable service to improve healthcare quality through precision audit and feedback. What does this mean? So essentially, Zach Landis-Lewis is the PI. He's in the Learning and Health Sciences School. He's a professor. He is excellent. He has incredible insight into the daily practice of medicine and workflow of physicians. And he teamed up with us at MPOG and Aspire to help us precisionize our feedback emails to make them more impactful and have providers or the recipients of the emails increase their satisfaction with how all of the data is being displayed. So right now, there's somewhat boring kind of bars with your percentage and relative to other people, and just has a pretty brief statement up here, sincerely the MPOG team, and then you have 4 to 6 measures that are chosen by either you or your institution, depending on how you participate in this email program. And you see those scores for you every single month. You can also go to the dashboard and see your scores on every measure, but you choose which 4 to 6 you consume monthly, essentially. And some quality program directors at different institutions pick at least of the fixed 4 that they want or that they have decided are the main agenda items that they're trying to work through or trying to improve at their institution. And so this kind of pictogram kind of goes over the intention. So essentially how we're doing this is using a precision feedback system to generate a high value message and to figure out how to be really precise and how to give people high volume or high value for what they're consuming. We need to know what they prefer and who they are, where they're practicing, and where they view their input being most impactful. And so this R01 has a kind of complicated conceptual model diagram of our aims and key system functions. But essentially, aim 1, we're taking a group of anesthesia providers, which have a bunch of different types of practitioners, residents, CRNAs, attendings, and CNAs, depending on the state you're in. And we kind of get their requirements and preferences. And the requirements are kind of what we need to actually present to them. So we need to say, these are the measures, the name of the measure has to be there. Some form of performance assessment has to be there. And then the person in aim 1 helps us determine what their preferences are. So that's through a series of surveys and interviews where they kind of rank order message templates and tell us what they find is the most helpful in the most helpful format for them. And then for aim 2, we're implementing this audit and feedback service, which pairs the information from all of these to apply to other similar individuals and feed that back to the providers in the emails that are given monthly. And then in step 5, which is part of aim 3, or step 4 and 5, we are doing a randomized control trial looking at patients or providers who did and did not get the automated and precision feedback emails and see if their performance changed at all on the measures themselves that they were receiving. And so as far as future impact and early results, in a early kind of experiment, there was a kind of semi-structured interview of 34 anesthesia providers, and the overall scores for the emails were found to be significantly positive in a one-tailed t-test. So we basically showed that people do have pretty significant differences in the way that they're obtaining their feedback, and the way that we are currently presenting it was not the top way that they chose to have their data presented. And so this suggests that precision feedback emails would be appropriate and would have a perceived benefit by providers. And sorry, the overall scores are pertaining to a 5-point Likert scale of the satisfaction given by their preferred email format. And so they actually found that the highest preference was for when there was a change. So people really, really wanted to know when they were improving or declining on something and were less interested if they were stable. So they wanted that message to say whatever measure that they had the biggest change on, so they could intervene on that first, because that's a highly intervenable sentence or statement or graphic. So I have references here, and